you. Good afternoon, colleagues, and thank you very much for joining this public meeting of the Isle of Wight Trust Board. I believe that Sarah, you will need to leave at some point, but we have your apologies at that point. And I still believe that Kemi may be joining us at some point as well, although I don't think she is online yet. I have to welcome Anna New, who is deputising for Jay Chappell, and I warmly welcome the representatives from CQC. Laura, good afternoon, and thank you for being with us. Clearly we have a quorum, and I've had no further declarations of interest over and above those which are on the General Register of Interests. If I can say, though, that I think it's really important, if possible, for members of the public who are attending this meeting to normally just before the start of a public meeting, all the board will be mingling, talking, discussing with members of the public. And I would be very grateful if you could make yourselves known to us through this system, as you would if it was a meeting in person. I think it probably adds to the transparency and the accuracy of the minutes. And I'm going to turn to those minutes now and ask for observations, any corrections, and if I may, I would just like to say that I'm not at all sure that the list of members of staff and public in attendance from last month's board is correct. And I think this will need amending. I think the answer is we don't actually know who attended last month, but we certainly know that some of those names did not. So if I may, apart from that, take us through the board minutes for accuracy. And if you're all ready, we're going to race through this. So hands up if there are any inaccuracies on what is page 2 of the board pack. 3, 4, 5, only 11 to go. No, 6, 7, 8. Joe.
Sorry, I put my hand up at 7. Just to say on the paragraph containing the issue of cancer appointments being down is actually cancer referrals, not cancer appointments. They're referrals in from the GP as opposed to appointments in the hospital.
Oh, thank you. Thank you. So if that amendment could be made, I would be grateful. So back to 8, 9. Tim?
Thanks, Melanie. Small point at the bottom of page 9, minute 20/T/104, paragraph 2. The quality reporting was actually transferred to the board in public and private, not just the private board during the COVID phase 1.
Yes, thank you. 10, 11. Thank you. So subject to those amendments, I believe the minutes are accurate. But Caroline, you have a point? Sorry.
Apologies, I was working on the wrong page numbers, so I was looking at my bottom line rather than my top. Page 10,
Yep.
Finance and Infrastructure 20T105, second paragraph, Anne Stoneham, who can also say something. I think the point Anne made was that limited assurance was because the meeting, the estate subcommittee was not quorate.
Yes.
It wasn't about the lead being unable to attend.
Yeah. Thank you. Thank you. Right. Any other points that should be made? If I may then lead on to the no outstanding actions to report. This rather unnerves me because normally there are actions to report. And in fact, I believe there was an action from the last board meeting, which was to do with the reporting, Joe, of certain post-COVID and pre-COVID metrics that has not actually, I think, been satisfactorily addressed in these papers, but may well be elsewhere. So if you could just bring that action back and check it, I would be very grateful. Thank you. Thank you. Right. In that case, I will, if I may, just spend a very few minutes on my update in connection with this particularly important board meeting. As we all know, without any hesitation, we are now in the second wave of COVID. We have the issues of elective care and the waiting lists. We have winter. And if on all that, we have Brexit on top of it. These are well-rehearsed issues, but they're incredibly important for this board to pay attention to today. These, together with the scale of the unknowns that we are facing at the moment, all require us as a board, a unitary board, full awareness of the risks in delivery to the operations of the Trust, the strain on the staff, and indeed on the executive as the next few weeks unfold. Today, I think it's very important that we as a board will, through noting the plans and the papers that are presented to us, be able to report our awareness of those risks, particularly through the BAF, and noting how those risks are identified, owned and managed by the executive. And we must be supportive of that effort by the executive, but it's particularly high burden of challenge on the chief executive and the executive team. I'm also minded of the vital importance of the daily pressures, which is quite exceptionally high, as you will see from the chief executive's report, where she reports on the daily OPAL levels. You will see also that we have weights increasing, 52-hour breaches. And in particular, I am concerned that we note, as far as we are able, through the slightly retrospective integrated performance report, but by the assurance from the executive leads of all the committees, that patient safety is not going unrecorded in any way, that we have full information at board level of such incredibly important metrics as patient safety, falls, pressure ulcers and infections. In that context, we cannot in any event just concentrate on the daily business as usual. We do also, as a board, as you are all well aware, have to continue with our strategic discussions in the context of all this work. And again, those papers will be brought to the board and we will have the opportunity of discussing. But I think in particular, and when you come to Maggie's, the Chief Executive's report, you will see the really active concerns and plans to address those concerns being demonstrated by our executive. So I will ask now that we have Maggie's report, and we will then have, no doubt, a substantive discussion following that. So Maggie, please.
So thanks, Melanie, and I will follow on in some of the context of what you've just outlined. So I will take it as my board paper has been read, and thank you, Melanie, for the feedback on the rather revised format. The summary points I want to highlight are that whilst to acknowledge that we are continuing to deliver healthcare in very challenging times, and whilst it is good news for our community that the number of confirmed cases of coronavirus remains very low here on the island overall, and this has meant that the number of admitted patients to our services remains low, the threat of coronavirus means that we have to implement very strict infection prevention and control measures. These measures are often counterintuitive to our normal practice, which is to be very open and to encourage visitors to visit and support their loved ones. Sadly, at this moment, this simply isn't possible, and I know that's hard for our patients, their families, and it is also hard for our staff. I think we're all sorry that this is the case, but we do have to follow a duty to follow the very best evidence-based guidelines at this present time. And I know that all of our staff are working in a very challenged situation. Our executive focus has, during the course of the month, and will continue to be going forward, been in several areas. So, as I've tried to indicate in the report, we are very focused on recovery of services from wave 1 of the pandemic. And as you can see, board members will have seen both in my report and from further board reports from Joe, that we have overall made good progress in that recovery. We're also very focused on the preparation for winter. And again, you will have seen in the board papers that we have the systems winter plan, and we will be having further conversations about the robustness of that winter plan in these very strange circumstances that we find ourselves operating within. We also have been working on the preparation for the impact of wave 2, and again I'm happy to take questions at the end of my report or during the course of the board meeting on the measures that we're taking to be as prepared locally as we possibly can be. Since my report was written, we've also had the exciting news of the emerging vaccine and also the release of lateral flow testing, the announcement about the release of the lateral flow testing for all frontline health workers. Currently, there are 34 NHS organisations who are piloting the rollout of that really great breakthrough in real-time testing. We're working with our ICS and regional NHS colleagues on the practicalities of both the forthcoming vaccine programme and the logistics of handling the lateral flow testing regimes. I will be able to supply more information both to our staff and to board members and our wider community as our understanding and our plans start to mature. EU exit is also an area that is occupying a considerable amount of our time, and again we're taking steps to ensure we are following all of the national guidelines that are released. We have got our Medical Director Steve Parker as our Senior Responsible Officer for our EU exit preparedness, and again through the course of the board meeting I'm sure we will hear more on this from Steve. On a separate note, while I was disappointed, I totally understand and respect the CQC's decision made during the month to cancel their forthcoming inspection of 2 of our services, and those services were acute and mental health and learning disabilities. They have made that decision at the very highest level of the CQC and based on the COVID restrictions, the national restrictions. And I will, of course, update board colleagues when we hear further news from CQC colleagues. In the meantime, our improvement journey will continue, and I continue to appreciate the efforts of all of our staff in the work that they are doing to improve the care that they provide. Moving on, I've mentioned in the paper our partnership work, and I'm happy to take questions on that now, Melanie, or I know that we've got a deeper paper prepared by Nikki, and I know we'll have the opportunity to have some discussion. Overall, we continue to make progress in securing greater resilience for our services, and we continue to be supported both by our ICP on the island and also our system ICS colleagues. I was very pleased, and it can't go amiss in this board meeting, to be able to say that the Trust Technology Enabled Care team, alongside good project management colleagues and the Care Home Support team, won an award for the best COVID-19 remote monitoring solution at the 2020 Health Tech Digital Awards. It is recognising the rapid improvement of telehealth, remote monitoring and the Attend Anywhere video consultation software across the island. My sincere thanks goes to the teams for the way they have worked to ensure the continuation of care for our island community throughout the pandemic, and it is really great that they got the recognition in the way they won this award. And I want to say good luck to our staff who've been shortlisted for Nursing Times Awards in 2 categories: enhancing patient dignity for the opening of the Weller unit and the end-of-life care that's provided. And members will remember that we had a very moving family story at last month's board on the positive impact the Wellow unit is having on our community. And in the category of Nurse Leader of the Year, Shane Moody, our Clinical Director and Consultant Nurse for the End-of-Life Care, has been nominated. So good luck to all those involved. I know I'm biased, and you would expect me to be, but if I were on the judging panel, they would all be winners. They would, both categories would be winners. And finally, Chair, I want to update board members on the fact that we are making good progress in this year's flu and staff survey campaigns. We are ahead of where we were this time last year in both of those campaigns, and I would encourage all our staff to participate in both, as this year, above and beyond all years, it's important for us not only to protect our staff from flu, but to collect their valuable views of working in our trust, so that we can use the information they provide us with to further improve our health and well-being, and our strive to be the employer of choice. So those are the highlights, Melanie, that I wanted to bring to board's attention. And again, very happy to take questions now, or for us to pick up some of the points as we get into the substance of the board papers. Thank you.
Thank you very much indeed, Maggie. And on behalf of all the board, I think we would wish to add our appreciation and congratulations to the team that has won the award, and indeed also wish the nominees for the Nursing Times Award every success. And we will look forward to your next board report. I think, colleagues, if I may, obviously we have hands raised, but I think, Maggie, for me and my perspective, I'd like a little bit more, if appropriate, from maybe Joe or indeed from you, about the two significant areas of risk at the moment, which is referrals from primary care and the emergency admissions for this month. Is it possible, please, if you could just lead us through a bit of the considerations on that, please?
Yeah, I'm going to bring Joe in at this point, because I know we've had some previous conversations about how we convey these messages both to our board, but also taking the opportunity of the board being held in public to raise some of this more awareness for our community. So Joe, do you want to start, and then I'll fill in at the end?
Sure. Thank you, Melanie. So the first issue in terms of the referrals coming in from GPs, on the face of it, that might seem like a good thing because it means there's less activity coming into the hospital. However, our concern is that there may be frail elderly patients that we're not accessing in the community, and they may be becoming iller and therefore will end up in ED and be admitted. And it is true to say that we're seeing an increase in emergency admissions coming into the hospital, and it is true that the majority of that increase is in the over 70s. Next week, we are having a Break the Cycle event, and as part of that event, we'll be working very closely with our community and primary care colleagues to see if we can inreach into more people's homes to do an assessment of the most needy. And we're able to identify who those people are because they're a small cohort of patients that are often responsible for significant numbers of admissions. So we're able to identify last year how many people came in more than 3 or 4 times in the year. And then we're going to have bespoke services for those patients so that we can inreach into there, and that way then it should cover off our concern about people in their homes. Melanie, what was the second point you wanted me to cover?
It was a pressure on your emergency department.
So that has created significant pressure, and I was going to cover that in the report. The increase in the emergency admissions has played out in a number of ways. So we have increased demand coming through the front door. We then have a reduced bed capacity, and the reason the bed capacity is reduced is we've had to take beds out to create a second ED, a hot ED, if you like, to try to treat positive patients. We've had to take beds out to create a second ITU. So that's reduced the bed capacity there. But probably the most significant loss of beds is because we now have to have 2 additional separate areas that have to be completely isolated, and they are for elective patients coming in for elective surgery and patients coming in for orthopedic surgery. And we don't have finite spaces that absolutely meet the demand. So we have to have areas that are slightly bigger. So at times during the week, you may have the elective area where you have 10 beds, but only 4 of the beds are occupied. But we can't, like we would have previously, put medical outliers in there, because as soon as we put a medical outlier in there, we'd have to stop the elective program. So all in all, we've lost about 10% of the bed capacity through all of these various measures. So increased demand, loss of capacity, and you can see that adds up to a significant problem. We've compounded that then by the fact that we have significant gaps in our medical rotas that we are addressing. I want to assure everybody that the hospital is safe, because we backfill those posts and we have locum doctors that come in and fill those posts. But the problem with that is, because we haven't got a consistency of medical staffing, our processes, our procedures, our model of care in the way that we work that get people back home as quickly as possible, these doctors coming in would be unfamiliar with those processes, and that then further compounds the whole issue. So next week we are having this break the cycle, which actually will look at the patients at home. We'll look at the people coming into ED and how we better manage them. It will also look at how we're discharging patients and how we could streamline that. And more than anything, it looks at the central processes within the wards to make sure that we're managing people through as quickly as possible. The whole idea is that we are able to re-establish our model of care, where people come in, go on a short stay ward or the assessment unit if needed, and are turned around quickly and sent home.
Thank you so much, Joe. That's really helpful. Gives a rounded picture to some of the risks that we are considering, but it's clearly incredibly important to have that early information, and that is of some reassurance. But just on the back of that, and I will give way to colleagues who have far more important views, still remains a significant risk to all our workforce in the next few months. And I just wonder whether, Maggie, the risk that infection might spread through the workforce will put additional pressure on all your services.
And indeed, Melanie, it already is putting pressure on our workforce. And I know Alice will be wanting to comment on that. We are following all of the national guidance on how we protect our staff to protect our community. And currently, the same advice that we see on the public see on the TV around what to do if they have symptoms and to how to self-isolate, we have to follow here. And it is a big strain on the services we provide. And as much as I've said in my report, the good news is that we're going to have the introduction of the lateral flow testing. I was with a group of other very senior NHS leaders yesterday discussing the impact that may have on us initially when it's rolled out, because as we all know, there is a high prevalence of asymptomatic prevalence amongst the community. And of course, when we start testing our patient-facing staff twice a week, we are going to pick up some of those members of staff. They will have to then isolate, and Alice and Joe and Steve, Leslie will have an operational role in ensuring that we're backfilling those posts. But as Joe has already outlined, a lot of our posts are covered by our doctors, particularly by locum staff, and that will put further strain on our ability to run the services in the way that we're striving to do, to continually improve, but also maintain high levels of safety. We know that the national lockdown and the impact that I think everybody on Ireland has seen, the changes, proposed changes for the ferry timetables, and again that impacts on our staff, particularly locum staff who may be just coming for a shift. So Melanie, I feel like a bit of a doom merchant, but I think it's very pertinent that you raise those points, because we are operational focused, our exec colleagues, and every problem that comes our way, then we look at how we can mitigate it and carry on providing the services. But as I said at the beginning of my report, our ability to continue to recover from wave 1 and provide services going forward through the next phase of the pandemic are going to become challenged. We are trying to reflect that, as other board colleagues will be able to describe through their reports, through all of our board governance assurance processes. But yes, we do face some real unquantifiable challenges as we go into this next period. And I'm grateful that you've given us the opportunity to highlight them.
Thank you. Thank you. And we bear all this very heavily in mind as we go through this afternoon. Colleagues, I have Sarah and then Julia and then Phil, please. Sarah.
Hello. Thank you. I just wanted to go back to the celebration really for the awards nominations of Shane Moody and the Well Award, not least because it's great, and I'm sure we highlight how they've done, but I just think it's a really good example of the improvement journey we've been on, where it was, we were very badly assessed on our end of life care, but through great leadership, working in partnership with Mountbatten, and then and focusing absolutely on patient need and the right thing to do, has got us from a place where we were way from good to a really excelling. So I just think it's not only congratulating to them, and I hope they win the award, but they have, in my view anyway, because I think, and we need to hold on to that journey and use it again in other areas. So I just wanted to highlight that.
Thank you so much, Sarah. I think that's hugely important and a timely reminder. Thank you. Julia.
Thank you, Melanie. Similar congratulations. This is obviously a very worrying time, and you're making huge progress. I was particularly interested in one of the awards, the award between TEC, the Trust TEC and care homes, because this is a sign, a really lovely sign of collaborative working across ourselves and our other care providers. So really good to see that. So well done on that. And I think actually very helpful in all sorts of other ways too for the people using services on the island. I had a question about primary care as well. I won't go into the same area that Melanie did, but it is very worrying that people are not referring themselves so much through primary care. And I'm wondering if we have sufficient data, Joe. This is probably a question for Joe, and it may be you want to answer this later on when you're coming forward with your report. But we know that these people are largely over 70. Are they coming from particular parts, particular GP practices? Are they people who don't want to use virtual services? There must be something that lies behind that, and we might not know the answers yet. But it's obviously very important that people stay at home, stay safe at home, and use primary care services. Thank you.
I can interject just before Joe comes on. I think if our CCG and primary care colleagues were in this meeting with us, they would also be able to demonstrate that their services are busier now than they were at this point last year. So this isn't for me, we've got many unanswered points yet, and Joe and his counterparts in the CCG are looking intensely at all of these points. But I think it's not that we don't feel, because we lack some of the evidence yet and the data, because we're working on it in real time now. We don't feel that this is everybody coming here instead of going to see their GPs. This is patients who are presenting to us, as along with another cohort of patients who are still using primary care. But Joe, I don't know if you want to say any more or pick it up in your paper.
You're mute, dear Joe, you're mute.
Sorry, I was just going to say, no, I think Maggie has covered it. And the only bit to add is that the purpose of next week is to start to put, to see if our theory around people not accessing primary care because of the virtual world and because they're worried about coming out is there. And we'll do that by reaching out into people's homes.
Thank you.
Can I just add that I didn't in any way mean to be critical of primary care. I know that they're working incredibly hard as well. It's just that there must be reasons why patients we need to know. We need to perhaps have more data, have a better understanding. So hopefully next week we'll bring that. Thank you.
We're also picking, Melanie, if I may, we're also picking this up with the ICP as well, because it's really important as a system. It's primary care, local authority, and also how we can work with the voluntary sector, Julia. So it's really important that as a system we're tackling this, not just as our organisation.
That's really helpful. Thank you. Thank you. Phil.
Thank you, Melanie. So we've spent some time talking about the pressures in the system, and many of those are outside of our control. But if we look at the flu campaign, yeah, that is largely within our control to increase the percentages. And I realise that if you look at the performance in terms of uptake is better than last year, but is there more that can be done to increase the percentage of those that have taken or had the flu vaccination in order to eliminate a potential risk?
Phil, if I may, I will call on Alice's expertise in this matter, because I do believe year on year since I've been here, but more particularly since Alice has joined us, the strong leadership that she's been provided has, we've seen an impact last year, and hopefully we will see improvements again this year. But Alice, are you able to, I don't want to steal all your thunder.
No, that's fine, thank you, and a really good question. So yes, you're right, Phil. We have got a higher percentage this year than we did have at the same time last year. Our frontline staff are being supported to have the vaccine. A number have refused, and if you go down into the IPR, there are slides that identify that. What we have also had is, as per usual, we have our vaccine delivery staggered. So we are waiting, we have still got more staff who want it, and we're waiting for that next delivery of vaccines. So we're doing nighttime walks, we're doing vaccine clinics where they can come in. We have to be mindful that staff don't always work Monday to Friday 9 till 5 and are able to leave the ward areas. So we've got peer vaccinators, and we are seeing week on week an increase in staff. The other thing that we have taken is opportunistic when we talk to staff about having the flu vaccine. If they don't want to have it, we take that form back, but we also talk to them about if there is a COVID vaccine, which of course we're now able to move forward with, would they receive that? And a large number of people who are refusing the flu vaccine are saying they will take a COVID vaccine, which I think is quite interesting from a behavioural psychology perspective. But we continue to work with staff, we continue to talk to them continuously about the importance of vaccinating themselves to not only keep themselves safe, but those that we're working with safe.
Thank you, Alice.
Thank you very much, Alice. Thank you. Slightly minded now of time, and we will be returning to some of these risks throughout the rest of the afternoon. But I think, Kirk, you want us now to have the pleasure of your video.
Yes, I think, thanks, Chair. I think Ellie's going to share it with members of the public who are on the Microsoft Teams live event, and she's going to pop it in the chat for this meeting so that colleagues can access it.
Hello, I wanted to be able to talk with you about dementia and the importance of dementia for us as the Isle of Wight NHS Trust, but also us as individuals. I know that people living with dementia have multiple needs, and I also know that carers who support them also have needs. When they come into our care, either acute through the ambulance, mental health, or indeed community, it can be quite a distressing time. We know as the Isle of Wight NHS Trust that we had a significant priority within our annual programme of work around developing dementia and supporting those that we work with and for. I'm delighted to be able to stand here and say that actually we do believe we've made significant progress. We know that the CQC told us that our wards weren't designed to help people who had dementia and who live with it on a daily basis. So we've made a number of small changes. Clearly we can't change the structure of the building, but we can change the fabric. They also told us that we needed to ensure our staff had the appropriate training. And again, we've worked closely with Maggie Bennett and Dr. Jones, to look at training that is specific for our staff and our island. I think the other area that we talked about with the CQC was around our documentation and how we ensure that there's a consistent handover whilst that patient is within our care. And that's really, really important. It's really critical that if the individual sitting in front of you can't tell you what needs to be done, that we have a record of it. And so again, we've worked with the teams and we've worked with other members of the wider community in the system about looking at things such as the This Is Me document, how we implement that and how we embed it. The other part is the dementia strategy. So again, we didn't have a strategy within the Isle of Wight NHS Trust about how we were going to care for patients with dementia sensitively and person-centred. And I'm delighted to say that in 2019 we launched the Trust Dementia Strategy, which is a really simple document so that everybody knows exactly what their expectations are, whether you're a patient or whether you're a carer or whether you're a member of staff. And that's really important. What we do, we have to do consistently. We know that also patients are still telling us that we haven't got it right. We know that we could continue to improve and develop our services. So we are continually reviewing what we're doing through the use of audits and through data that we have collected. But I absolutely know that none of this is helpful if it doesn't make a difference to those people that we work for. So what we have done, which has been really impactful, is to look at two new key roles within the organisation. One is around dementia champions, and these are based around the organisation, and I'm absolutely delighted to say that we now have 47 of them, and that really is going to start to put some energy and pace behind the changes that we need to continue to make. The other role is two associate practitioners for dementia who are working currently in the acute sector, but we are looking at whether this model can be moved further out into the trust. These two individuals who you will hear from make a difference to patients every single day, and the contact and interaction they have is phenomenal. And for me, the biggest thing is when they come back into the office at the end of a day and you ask them what they've done, and they'll say to you, a patient who was looking lonely and lost at a particular moment, they went up, were able to sit with them for a few moments and maybe got a smile. What we do makes a difference, and we have to know that that difference is made every time. Thank you.
Hello, my name is Beverly and I'm one of the Associate Practitioners for Dementia. I received a telephone call one morning from one of our Deputy Sisters. A patient had passed away sadly overnight. The patient, however, was the main carer for his wife, who had a diagnosis of dementia. The Deputy Sister had to call the wife to inform her of her husband's passing, and she was concerned that she felt that his wife hadn't taken on board what happened, and she'd also refused any offers of help or support. The Deputy Sister had called and wondered if there was any avenues that we could open up to support the patient in the community. After thinking about this, we decided to go and speak to Age UK, who are part of our integrated discharge team within the hospital. I spoke to a colleague and gave the details, and he said he would have a look and come back to me. I went back to my office to discover that the Deputy Sister had been on the telephone again and to let me know that the GP had had a telephone call from the patient's wife, and he was concerned, and as she was very distressed. I then shared this information again with my colleague in Age UK, and within 10 minutes he'd come back to me to say that he'd arranged for rapid response to go to the patient and check to see that she was okay. This event left me with a real sense of pride, as this team effort provided wraparound care to a lady who wasn't our patient, but she needed our help at a really difficult time.
Hello, my name is Charlotte. I'm one of the other associate practitioners for dementia. When I was on the ward one day, one of our patients was extremely agitated. She'd been banging on windows, she was trying to get out of the ward, she was desperate to go home. The HCA with her was desperately trying to calm her down, but had exhausted all of her options. The doors to the ward and the bay had already been shut to try and deter the lady from leaving. I went up to the lady and I tried to converse with her and just understand why she was feeling the way she was. But it was clear at this point there was far too many people around her and it was making her feel overwhelmed. We then agreed that everyone else would back off and I would spend a bit of time with the lady to see if I could calm her down. As everyone left, I then approached the lady again to try and see how I could help to calm her down. It became obvious at this point that the more I intervened, the more agitated she became. I then decided to approach it from a different angle where I actually backed off the lady a little bit and allowed her that space to process what she was feeling and what she was thinking, because everything that she was feeling was very real to her. As I backed off the lady, she started to calm down and settle more. She then also returned to her bed space and sat down. From being distanced from the lady, I was able to keep an eye on her and make sure that she was safe and no harm was going to come to her or any of the other patients in the ward. But it also just allowed her breathing space and time to process everything and calm down without everyone trying to intervene and find out what was wrong. When I went home that night, the situation had been playing on my mind a lot about how the lady was feeling. So the next morning when I came in, I decided to go and visit her and see how she was. She was a lot calmer than what she was the day before. I then also looked in her folder and realised she didn't have a This Is Me, so I decided that due to the situation yesterday, it'd be a good idea to get in contact with her son and hopefully he'd be able to help me complete one over the phone. When I actually got in contact with her son to do the This Is Me, he expressed his concerns about how the lady didn't like being away from home. And that's not just with hospital, it goes back to even when she used to go on holiday, she did not like being away from her own home. The This Is Me document provides us with an invaluable insight into who our patients are and allows us to support them in the best way possible whilst they're in hospital.
Hello everyone, we're now back into the meeting. Apologies for those who lost the sound halfway through the video. The sound was playing at the beginning of the video, so I'm not sure what the hitch is for it to stop halfway through. However, I will put a link in the chat so that you can watch it. Back to the meeting.
Well, thank you very much indeed. Really appreciated the work and effort into bringing something as pertinent directly to us, to really appreciate the work that you are all doing and the importance of the work. I do note that there have been some answers to questions from the public already in the chat box, and I'm presuming that will be able to continue throughout this afternoon. But thank you very much indeed, and please do take all the board's congratulations to the dementia service team, and particularly I think the dementia champions, who will make a difference cumulatively time after time over the years. Thank you. Now, I do have questions, I believe, from Phil. Is this a new hand or an old hand?
An old hand, sorry, Melanie.
In that case, Sarah, I think this is a new hand.
Yes, it's a new hand. Thank you. Yes, really great to see how these services are progressing, and great work, everyone. It just occurred to me that I wondered if there was an ambition for those people who are admitted to our services with dementia at their point of admission to think through the relationship with their carers and how that's going to be managed. It came across, and I might be wrong, as a bit of a surprise to the team that the carer was going to struggle should anything happen to the patient who sadly died. So I just wondered if where our next steps are with this and what's our next plan to move this even further, or have I just missed something in terms of this is just a snapshot? Thank you.
Do you want me to reply to that, Sarah, very quickly? You are absolutely correct. I think sometimes people only look at the person they have sitting in front of them, and it's not just dementia. There are other areas where we need to make sure that everybody thinks about those people that are either at home or that they are caring for or being cared for by. With the dementia champions, I think both of them, or practitioners, both of them are relatively new, so I think are still learning about how systems work. One of the things they have made a huge impact with is the This Is Me document, which clearly articulates who is at home and who is caring for them and what they need to happen. And I think this particularly, one of the reasons for sharing that story was just around how being part of a system island-wide network provides us all with some support so that, you know, individuals in their own homes know where to contact and come to. It's a learning, and I think dementia has moved in the right direction, but it's a long way off where we would want it to be. So there is an ambition to make sure we're part of a much wider system. We are linked into the Island Network for Dementia with Maggie Bennett and all the amazing work she's doing across the Isle of Wight, but there is always more that we can do.
Thank you.
Thank you. Maggie, you want to come on back on that?
Yeah, I just wanted to ask Alice a question, if I may. Dementia is one of our key quality improvement streams, and I just wondered, Alice, if you could explain how we're monitoring improvement. So you had the dementia strategy in the video, and I just think some assurances around, I mean, I think you just said we're a long way off where we want to be, but we have moved considerably on our improvement journey. So how are we monitoring it, and where does it get fed to?
Yeah, no, that's a very good point, Maggie. There's no point in saying you're improving if you've got no evidence for it. So I'm delighted to say that we now have in the organisation a dementia steering group, and we are now starting to work with the dashboard. So part of that dashboard is absolutely monitoring the improvements that we're making. So, for example, we monitor the mandatory training, and we brought in a specialist package with Maggie and an external dementia guru to be able to deliver improvements for all of our staff so that they've got the relevant training. We look at the percentage of patients who not only hold a This Is Me document, but for whom that This Is Me document is meaningfully supported and filled in while they're within us inpatients. We've looked at the average length of stay because we know that for dementia patients that can sometimes be longer, so we want to see that reduced so that we're caring for them at home. We look at things like complaints, percentage of patients who have fallen, and what their harm has been, and also the onward destination. So we also know there's a number of times we have discharges from a ward, but they don't go back to their original place of residence, and that's sometimes not out of their choice or their carer's choice. So again, we're looking at all of that as a data set. And then throughout the work, we also have had some really good work with our mental health colleagues, and thinking about how we can support people in the community and develop some really clear pathways. So again, we will look at that pathway work as we move on. We now have a clear vision and plan for the work, and we're able to identify that we're improving.
Thank you. Thank you very much indeed. I think, colleagues, in that case, again with thanks for that video, can we maybe move on to Nikki and the transformation update?
Thank you, Melanie. Yes, as with others, I'm going to assume that everybody's had the opportunity to read my report, but there's a few key points I'd just like to draw out this afternoon around each of the partnerships. Whilst bearing in mind some of the risks we've already discussed as well during earlier reports this afternoon. Around acute, I'm really pleased to let the board know that we have welcomed 3 members of our core programme team in the last few weeks, and that's really important, because we're trying to maintain the pace of the work that we know we're undertaking now, particularly in developing our implementation plans, and we know we need to give as much support to our operational clinical teams to help them achieve some of our objectives. I'm also pleased to note as well that the importance of this partnership and programme has been recognised by NHS E&I, both regionally and nationally, and they have kindly offered some financial support for the rest of the year, which helps aid some backfill to posts that enables us to deliver some of the programmes of work that we've outlined in past reports. And we are seeing progress. We're moving into that delivery phase, and with the programme director and programme managers, we'll be able to articulate far clearly to the board each step that we intend to take. One of our key objectives to achieve some significant shifts in delivery by October 21. So that's a key milestone and a lot of activity to get us to that point, particularly around core emergency services. Around ambulance, Maggie mentioned earlier around the PTS CAD becoming operational live this month. What that's enabled the teams to do also is to pilot within 5 of the acute wards a direct booking service. Again, that makes our processes a lot slicker. It helps our patients that need that type of support to return home, or maybe to another mainland hospital, to be able to be done very quickly. Again, it helps improve the use of our resources. Our work with SCAS continues around the telephony system. Again, our hardware is on site, not operationalised yet, but the information system itself has been ordered as well. So the programme of work that wraps around that is focused on delivery over the next 4 months. So again, good progress in that area. Maggie mentioned as well in her report around the fact that we have our 4th and final partner, and that sort of concludes a particular piece of work around partnerships in getting partners in place, and having Solent as partner for not only community but also mental health. Lots of learning and sharing, a very strong relationship already established there, and I know the senior teams within community services at the moment are getting together to look at the next steps, their key areas of focus. But again, it's a very two-way thing, lots of learning, as we've heard earlier around community services, a lot to offer from an island perspective as well. I'm just going to pause there and hand over to Leslie Stevens just to give some highlights around the mental health partnership, if I can.
Thank you, Nikki. As the board is aware, we brought the mental health and learning disability strategy to board last month, and it was signed off. And the work that's been happening this month is really focusing on implementation. We'll be bringing a full implementation plan to our mental health board next week, and that will come to trust board next month. But there's lots of work that's in progress. For example, the leadership structure within the division has been remodelled to enable implementation of the strategy. And one of the things that we've done as part of that change to our leadership structure is introduce a new shared role with the CCG that will allow us to bring together the transformation elements of the CCG role with our operational management role, so that we've got one shared role working across both the CCG and the mental health division, which I think will really allow us to move more rapidly in terms of implementation and decision making. So that's, I think, a really helpful development. There's work going on to get into the detail of the clinical pathways and what the new model will mean for people accessing services and the responsiveness of services, and that is informing a review of our workforce and allowing us to get people into the right place to be able to deliver the new model.
There's really active work going on at the moment to recruit to the new schools mental health support teams, and we're seeing some, again, really innovative practice around recruitment happening. Given that we can't do face-to-face interviews, actually they're finding other ways of doing interviews that have been great, and there's been a really good response to that recruitment. So I think a real energy around the development of that new service that will bring a lot of benefit to the island. And we've started a pilot of the locality integrated model in the south of the island, and that also is progressing really well. So lots of activity happening around the strategy implementation at the moment.
Thank you. Nikki, is that, I just would like to thank you both, but really pleased to note on what is page 8 of this slide deck, the identification of risks. Clearly there are many more as well to implementation, but as a board we do need to be absolutely alert to that at all times. And in particular, any transfer of services between staff, I do think has to be very much on the board's mind. So colleagues, with your observations, thank you. I think Kemi, thank you, welcome. You have a point.
I do. I first wanted to say I like the fact that all the partnerships are making progress, and this report is nice and compact and clear. As a board member, there is something that I struggle with though, and it's in understanding what outcomes these various streams of activity will deliver. Because I could say, yes, I think, it looks like a lot's happening and they look like good things. And I really liked the table in the acute services delivery plan. But when I got into the 4 colored columns, I realized most of those are activity rather than outcomes. So I think my question to you is, how do we as a board start to understand what this activity is contributing to deliver, such that when we actually come to judge the partnerships, we're able to say whether we're actually delivering what we planned to. So really positive that things are moving on, but I'm struggling as a board member to be able to objectively judge the outcome. And similarly around the risks, when I look at the list of risks, I'm not clear on which are high risk, which are medium. They're just a set of risks presented. And I also don't know whether the activities you've described, the extent to which they're going to mitigate those risks. There's a level of information that we don't need too deep, but enough such that we can say, yes, we're engaged and we understand what you're doing. That's what I would say from my perspective.
Thank you, Kemi. Shall I, before I ask for a response, shall I ask others for comments, and then we could do a consolidated response session? So, Phil?
Thank you, Melanie. I had 2 questions, one in relation to ambulance and the telephony system and the degree of confidence about the implementation date, because I know that we've spoken about the telephony system on a few occasions. And I think, Nikki, you indicated that was 4 months away, but it was just whether we had a definite date for that and how confident we were in it. And the second was in relation to mental health and learning disabilities and strategy and engagement. And the last board meeting, we had some very positive sort of reactions of the board to the strategy. And I know it looks as though that we've started the engagement process more broadly, but I couldn't get a sense of the reaction of that, through that engagement process. So what's there's a reference to a public launch. What's the reaction been like to the public launch?
Thank you. Anne, what questions have you got?
Thanks, Melanie. Actually, my question was related to what Kemi's was about risk, really, but I suppose I wanted to sort of frame it slightly differently, because I did want to get a sense of which risks we thought were most likely to materialise, but probably more important than that for me is that of the mitigations that will address those risks, which are the ones which are primarily within our control that we can perhaps do more about? Because I would like to get an understanding of those, because I think the mitigations we can control are the things which will help us actually address those risks. So I wanted really a little bit more information around that.
Thank you. A group of questions around risk. Caroline?
Yes, I was going to add to the questions on risk. I was sort of following Melanie and saying well, it was good to see page 8 and us starting to get to think about that. But to frame the question a little bit differently, perhaps using the example of current partnerships aren't able to demonstrate clinical and financial sustainable solutions. We haven't yet set the partnerships the objective of a financially sustainable solution, and therefore I felt that the risk mitigation in this particular one was really around very long-term mitigation, and there were probably some mitigations that were more short-term about sort of reframing the partnerships, which we've already agreed in our strategy, that would help us sort of get more control over risk. So I think my observation was, this is a good start, but I thought we could do a little bit more about how we frame that chart and get those mitigations into the sort of short and long term, and to pick up Anne's point, based on immediate outcomes that we can influence versus long-term plans.
Thank you. Julia, you wanted to add a question or area of questions?
Add to the questions already around risk, I think. But given what's been said, I thought I might start with a real positive feeling being generated by the way in which you've achieved partnerships through building relationships, and we all know that that's one of the things that can cause problems in new partnerships, but you've done that very successfully. So I wonder whether the first risk, current partnerships aren't able to demonstrate clinical and financial sustainable solutions, which is absolutely key. They have to, otherwise what's the point in doing them? Whether that isn't perhaps overstated, and I would like to know, I think going back to Caroline's suggestion, if you could break that down into short term and medium and longer term, that would be very helpful. And I mean, not now, obviously, but in due course.
Thank you. And finally, just to add to the list of questions, Sarah.
Okay, mine's not really risk, so I'll start.
Yeah.
I'm just interested in our latest partnership with Community, and I just I'm a bit confused, I think, about the partnership board and how that is developing and what the aim of that is. I just think we need to remember that this in some respects is a different sort of partnership that we've gone into, or the reasons for it we've gone into slightly differently, because our community services are quite strong locally, and I think the partnership board needs to reflect this. So I would suggest that the board needs all the partners, all those people who can contribute to developing really good local health and social care services to our community, rather than just be about a partnership with another NHS provider. And I'm not clear from the way it's written in the transformation report that that's the proposal, which I feel quite strongly it should be. Because I think we need to recognise that our community is here, it's strong, and we do need support from other services, but I don't feel it needs to be led by that. And I know that's maybe a connection with the ICP, but I'm not clear what the Community Partnership Board is designed to look at and be there. So that's my just reflection on that.
Thank you very much indeed. And I just would say that this, of course, is only the update for October. So I think some of these questions are ongoing questions which will be addressed in due course. And so I won't ask Nikki necessarily to answer every single one. But I think, Nikki, you do take on board the concerns we have about risk. And that would be an important thing to bring back to the next update. Certainly about monitoring of outcomes, absolutely. And I think we would expect that and will anticipate it. And maybe one or two specifics on the progress within partnerships. but I don't think there is, because it is simply a monthly update. Is there anything else you want to add to that, Nikki?
I think absolutely all points are well made, and with the introduction of the programme team, you will see that evolution in outcome focused information in reports, as well as risks in more detail. So what we've done is very high level at this point. I think I just wanted to make a comment on what Phil said around telephony specifically, and confidence around delivery dates. The current programme plan aims to deliver the first phase of telephony by the end of February. That's what the focus is at the moment, but there is a second phase to that because we're doing this in partnership. SCAS are also in the process, and will be in the process of rolling out the same telephony system. So what we need to do is an alignment piece in the end of Q1 into the beginning of Q1 in 21-22 as well, which is really important to make it effective to work across both organisations. So just to note that, but take every other point on board, and also Sarah's point around the community partnership. I just wanted to check whether either Alice or Leslie wanted to make any comments from what's been pointed out this afternoon.
I wanted to respond to Phil's question about response to publication of the strategy. We've had a very positive response so far, but the strategy was built on engagement, so I don't think it was a surprise to any of the people that it's been shared with, and the implementation continues to build on the engagement approach that we developed through that process, using the kind of remote technology to enable staff and people who use services and others to keep involved in the implementation programme. We're working with an external company at the moment called IMROC, who are experts in co-production, and they're particularly supporting us with strengthening our co-production through the implementation of the programme, and making sure that we're building on the work that we've done already in getting people with lived experience and their families and carers to be really fully involved every step of the way. I think we've made good progress with that, but there's more that we could do, and we want to push that further.
Thank you very much indeed, Nikki. I'm so glad you've got extra staff resource. Thank you. If we can, colleagues, I think we ought to move on to winter planning. And Joe, please, item 10.
Thank you, Melanie. I'm going to take the paper as read, but just want to highlight a number of issues. This is a live document, so as soon as it's gone to press, things change, and we're continuing to have meetings with our healthcare partners. The plan, which has been presented here in September and is now here for final sign-off, covers a number of things that you would expect in the winter plan. It covers bed modelling scenarios and outlines our mitigations. The plan, as it stands at the moment, had a scenario in which we saw 8% increase in activity and extending lengths of stay. And at that point, we didn't have a mitigation of how we would accommodate patients. Well, I'm pleased to say that we now have a mitigation for that, and we could accommodate that level of surge, with the exception of having a robust plan around how we would staff and manage that. So the staffing remains, I think, the key risk. The plan covers all of the other areas that you might expect: escalation, data management processes. It also covers flows through the hospital. The plan takes in a number of other remits as well. So it sits outside the hospital and also across the hospital of areas of other directors' responsibility, such as flu planning and adverse weather conditions. I'll stop there in terms of highlighting what's in the plan, and instead take people's questions, if you like, in terms of any questions you might have about how we're progressing.
Thank you very much, Joe. Clearly, this is a hugely important report, and take the point that it is a live document. We will have colleagues' queries, But I just wonder, and it almost relates not only to this item, but the previous one. Isabel has offered to just give a comment, I think, on the ambulance services. And I must confess that I am personally concerned about the interface between potential ambulance delays and ED capacity during this winter period. So, Isabel, could I ask?
Yeah, I'm happy. I was offering to respond to the previous one, but yes. I'm happy to try all. I mean, essentially, answering the range of questions. We're doing a lot of activities around aligning what we're doing on a digital platform to enable us to work together in a and to share best practice and so on across the two organisations. And that's what the aim is. And ultimately, it's the performance against national standards is where the benefits should be seen. And the urgent activity is to make sure you have a telephony platform in place, even if it's not in use, ready for that. Across coming to ambulance delays and handovers and so on, we are seeing in SCAS, to give it some perspective, issues in just about every area with the question of ambulance handover and delays, because every ED is having to manage social distance requirements, operational changes and so on. So in every scenario, there is a splitting of flows and a separation of people and basically a slowing down of all the things we might previously have done to manage a smooth and quick handover, which ends up with lots of people rather too close to each other for now. So it's absolutely not an island specific issue. It's a shared one. So just to give it that context. Unfortunately, that also means I don't come ready with the answers to it. Just to give you the perspective, it's a really, really challenging question for everybody. The places that will get through to the ones who work in an integrated way and look at the system and the flows together, rather than end up as a sort of battleground between different organisations. So I think the island is very well placed to manage the risk. But I wouldn't want you to think it's an easy risk to manage. I don't know whether that helps really, or the answer you were hoping for.
No, I wasn't expecting an answer, I'm afraid, because it is such a problem across the whole country. But that's a really helpful commentary for us to bear in mind. So thank you. Again, I'm going to ask for what the area of question or observation each has, and then ask Jo to respond at the end. Although Alice.
Yeah, so mine's just a very quick one, and it strikes me as Jo's talking about this, it might be worth, and I don't like to ask Leslie to do this without having spoken to her previously, for us to get our mental health and community winter plans to be able to support this, so that you can see the totality. It's not just the acute one, and that we are working together. So that was all. It was a statement more than anything.
I think that's really helpful. Thank you. Thank you. Anne.
Yes, thank you, Melanie. I think it was just to pick up with Jo, really, the points that he made about the problems you'd had last year in relation to variation in data sources, which reporting and decision making depend on, and also the inconsistency in escalation responses. And I wanted to just get an understanding of the confidence, levels of confidence you have that of the improvements and changes in the system, which will ensure that perhaps we don't have quite the same problems this year.
That would be really helpful. Caroline?
Similar question to Anne, and I'll just ask it in my own way so that it's consolidated by Jo. Yes, I think from last 2 years, our success has been around how we've managed flow and handover, and how we've managed escalation and cooperation between all of our divisions and between the agencies. So just going to ask Jo to give some further briefing on his confidence in those issues.
Thank you. Sarah, and then I'll come to Kirk, who I think wishes to. Sarah?
Thank you, and welcome all the work. I know there's a massive amount. There's a couple of areas I just wanted to pick up very quickly. One is I just wondered how confident you are that our partners in adult social care and primary care have been able to prepare as well as you, and are able to up from where they are now with their COVID and responses and to this. I know that, I know they've got struggles of their own, and I just wondered how confident we were that that was there, and is there any support we ought to be trying to support them with. And I also was wondering if there's been any, we've considered the differential impact on different groups of our community with winter and planning, and that goes with COVID as well, but whether it's the disabled, those with dementia, learning disabilities, mental health and children. And I just wondered if we've sort of done it by numbers and increasing, but I just wondered if we have considered the differential needs of different population groups, and we could be assured about that. Thank you.
Thank you, and I'm absolutely sure that Jo will give us some very robust answers to that, but maybe Kirk first and then back to Jo. Kirk.
Schoolboy error. Thanks, Melanie. Just wanted to say, Jo, I think it's a really clear, detailed report. So thanks for that. I think there's something quite crucial in all of this, following on from what Sarah has just said about different parts of our community. I think there's such a huge amount going on for people in health and public services in general with COVID, the response and recovery, and also with winter. I wonder whether there is a clear message for patients and the public in general about what we want them to do during this period. The national campaign Help Us Help You and the rollout of NHS 111 First gives us a really good opportunity to be clear about what the public can do. And I wonder, Jo, if you support my suggestion that we need to be a bit more proactive as an organisation in communicating with the public about using 111 First, and about reaching out to their GP and accessing services early so that they're not more poorly when they eventually get to us.
Thank you, Kirk, and I think you've just got yourself a whole load of work to do tomorrow. Absolutely. I think all the board would agree that this is incredibly important on behalf of the Trust. So subject there too, Jo, any quick observations on our concerns about the level of confidence in some of the challenges and the mitigations that you have identified?
I'll take the information, the shared information first that Anne and Caroline led into as well. As we went through the COVID period, we refined all of the communications that we had internally and externally. So pre-COVID, we had Section 2s, Section 5s, various other forms that flew around the place, went backwards and forwards, and caused a great deal of confusion. They've all been stripped out and streamlined now, so there is one discharge assessment form that goes between everybody. We created an integrated discharge team which flows from inside the organisation outside, and therefore it pulls the information through in one team. In addition to that, we refined a lot of the systems we're using as well, and spent a lot of time over a lot of arguments as we went through the COVID situation of trying to get to one version of the truth. So the endless debates that we had with, you said this patient is in, we said that patient is in, we have refined that significantly. There are still areas of concern that we have to work through. It's not perfect yet, but we're making progress with it. And now it's an exception rather than the rule that we have the same cohort of patients that we're all working on together. So I'm a lot more confident in the information flows. I'm more confident of the inputs that are going into Shrewd, and Shrewd is the system that we use to manage system-wide. Again, there is a considerable way to go with getting those inputs to where we would like them, but they've certainly moved in the right direction. So I have more confidence in that side of things, in that it's coming together. In terms of the flows and the handovers that we spoke about, Well, of course, you know, historically here, we've never really had problems with ambulance handovers sort of pre-COVID levels. And now it's something that we are seeing, as Isabel has described, in many ways because of the separation that we have to have, the constriction within the ED, but more importantly, the restrictions outside the ED in terms of us being able to flow patients out. That's the key factor. The 111 First programme, which we are a first follower of, will help us pick up with that, because it'll allow us to redirect ambulances away from the ED into the STEC and into other areas, so that we will be able to take some of the pressure off the ED and improve the flow process. Again, we have to create the capacity downstream to allow the ambulances to be able to get into the STEC and do that. And when we're able to embed our model of care, our acute medical unit will change into an assessment unit, which means there'll be 24-hour assessment beds available with just a 24-hour length of stay in there. So again, that will be able to pull through on the flow. So I'm confident that the flows will improve if we can get the model of care right and we can clear out the hospital. And that, of course, is all dependent on making sure that we continue to manage COVID and we have the infection control procedures in place to do that. The differential impact is picked up through, I would say, through our normal standard operating procedures, because we have procedures in place that we look at for learning disabilities, we look at for mental health, we look at for care of the elderly. And basically the winter plan, all the winter plan does is it picks up all of these lines that point into the hospital and all of these activities that we undertake in the community, and says, how will winter affect these areas, and do we need to do something additional about them? We clearly need to do something different this year, particularly with the frail elderly at home, and that's the whole point of next week in terms of trying to get out to those patients. I think Leslie will talk about the work that, the enormous amount of work that COVID has now placed on patients with mental health difficulties and with learning difficulties. And I think that's a particular strain as well this year. But again, that's getting picked up through plans, but we haven't written specific protocols outside the normal protocols that we would use. We sort of added to them, built on them and strengthened them. Kirk, thank you for the offer of the proactive approach. As you know, we have been working on the 111 and we've been doing really well with the Think 111 First, and you know, we were highly commended in our last meeting, but it's certainly an area that we want to get out to the public. Is if we can start thinking 111 first, we can actually book the majority of people into our urgent treatment centre and into our ED. 66% of the activity that comes through the front door is self-presenting, and that's what we really need to get to in terms of, if those patients would come through 111, we would be able to flatten that massive curve that you get in terms of people coming in. So I'm happy to work with you on that, Kirk, in terms of how we might improve the messaging.
Thank you. Thank you very much. Anne, is it, was it an old hand? Yeah, thank you. Joe, thank you very much indeed. Clearly a huge challenge ahead for all the executive team over the winter. Please do keep us updated to the extent that the board is concerned about the risks to delivery and wants to do everything it can to support you and all your colleagues in ensuring the best possible care for the island at this crucial time. And it really leads into the next part of the agenda, and you're going to have to wait until a comfort break, I am afraid, because I think this is too important, to lead into the consideration of the Quality and Performance Committee, but also in connection with that section of the IPR that relates to the performance and quality metrics. So Lois, I believe you want to lead, and then of course Tim.
No, I was very happy to hand over to Tim. He has briefed and well prepared to go ahead with this.
I have no doubt. Tim, thank you.
Thank you very much, Melanie. I won't go through all the points in the paper, but just add a few additional points. Firstly, in respect of the quality account, one of the highlights for me in the quality accounts, which, as members will know, is a fairly large and large document in a very prescribed format. There's a large section quite close to the beginning on the progress that's been made on last year's quality objectives and the setting of quality objectives for the coming year. And it's very pleasing to see that there's been enormous progress on the quality objectives over the last period. This is, of course, the period to March this year, because publication of the quality account was delayed due to COVID. And further objectives have been set out in the same domains as last year for the coming year. I'd also just like to comment that the stakeholders of the organisation are given an opportunity to comment, and we're required to do that, and we're required to publish their commentary. And the feedback we've had from our stakeholders this year is exceptionally warm and supportive, and certainly the best we've had in the time that I've been in the organisation. And I think probably the best set of supportive statements that I've seen in my career, actually. So that was really is a real testament to the improvement that has gone on in the last 2 years. We then went on to receive a very detailed paper about CQC regulatory compliance, which had been assembled with the assistance of Alan Thorne, who's been the Trust's Improvement Director for the last 2 years, and is formally a senior inspector with the CQC. And he's done a very detailed analysis of the entire organisation, service by service. There's been excellent progress on the must-dos and the should-dos and regulatory compliance actions against previous reports. And whilst we're not in the business of forecasting what the CQC might say, Alan has he's risk assessed the chances of us not achieving an improvement in our rating, and in most areas that is low, and in the worst case moderate. So I think we've got a positive story to tell the CQC, and I think we're genuinely disappointed that the upcoming inspection has had to be cancelled, although we fully understand the reasons why in the light of the second wave of COVID. Our quality heat map is nearly operational now. We actually caught sight of it at this meeting. It's not quite ready to be used in anger yet, so we'll be continuing to use existing quality dashboards for a while longer. On the maternity quality report, the board will be aware that we have to submit a set of data and board signed off assurances to the NHS resolution and the clinical negligence scheme for trusts to indicate the quality of our maternity services and the progress we're making against it. And in return for those assurances, we get a substantial discount on our insurance premiums for that service. That process has been suspended during the COVID outbreak, but it is just about to go live again. So in the not too distant future, the board will be receiving a recommendation around that. And of course, these submissions are incredibly important that they're accurate, because they are randomly audited. And if we're found to have made a false declaration or an inaccurate declaration, the discount potentially is repayable. We then considered in some detail the Infection Prevention and Control Board Assurance Framework. This is a huge template sent out by NHS England, particularly in the light of the infection prevention and control measures to prevent COVID spread and nosocomial infection in the hospital. A lot of work has gone into this, and we got a great deal of assurance that those few risks which have not yet been dealt with have been mitigated, and there are plans for closure on all of them. We had a good discussion about virtual consultations with a video interview with a physician that actually only sees patients virtually, which was quite interesting. unfortunately, since the end of the last the COVID phase 1, there's been quite a steep decline in telephone consultations. But the video consultations, although they've not been used very extensively, they are most used in mental health and learning disabilities, particularly for the delivery of psychological therapies, which of course is quite difficult where you've got patients with recurrent appointments to do face-to-face in a COVID secure fashion. Whilst on the subject of mental health, we went on to consider the Mental Health Act quarterly report. We monitor the use of the Mental Health Act on behalf of the board and seek assurance that that the operation of these particular sections are being operated in compliance with the law. We're satisfied that they are being used in compliance with the law, but there was a small increase in the use of the Mental Health Act during COVID, particularly in section 136 detentions, which is the section of the Mental Health Act that gives the police powers to detain individuals in a public place and remove them to a place of safety. We don't have explanations for that rise at the current time, but I understand that's being investigated and we'll receive that at a later date. And we were substantially assured by the improvement in all the metrics that are in the mental health performance report. Remaining on the subject of the performance reports, the data in the IPR regarding ambulance performance is concerning in that the service is not currently able to meet the national standards. That's already been commented on in part in this meeting. Of course, it is a very small service delivered over a proportionately very large geographical area. And that does make it fragile when demand increases. And I think the conversation we've just had about delays in ambulance handovers is very pertinent. I think the worst case that's been reported in the UK so far in the Thames estuary was ambulance offload delays of up to 5 hours. Now, clearly, if something like that were to happen on the island, the ambulance service would not be able to function at all. So with a small ambulance service, it's absolutely critical that we don't allow offload delays to occur. Going on to the acute hospital performance, we had a good conversation about ED performance and why it is struggling at the moment. And I won't repeat all the detail around it because I think Joe very ably explained it to us earlier in this meeting. But it does highlight the difference between the apparent bed occupancy versus the true bed occupancy. And although the reported bed occupancy is around about 87%, in reality, when you take out beds that can't be used from the denominator, it ends up being nearer to 98%. We also had some detailed data, which is also in the IPR, around RTT, which is the referral to treatment time standard for elective operations and appointments. And we took a look at what's known as the patient tracking list report. And I think just from looking at that, there is nothing worrying in that we don't already know. So that gave us a significant level of assurance that we do know the size of the problem and we know where it is. And we were very encouraged by the good progress on restoration and recovery that has taken place, and in particular in some of the diagnostic services that are operating at well over 100% of their performance pre-COVID. Thank you, Melanie. I'll stop there.
Thank you very much indeed, Tim. I'm just going to ask the executive directors that report into the Quality and Performance Committee as to whether they have any further risks to identify for the month going forward over and above those which have been well rehearsed throughout the day today. But therefore, the question goes to Alice, to Steve, and to Joe.
Melanie, if I might come in first, I guess it would be the obvious one for us around the impact of COVID across the system of our emergency department flow through to the discharge, and it's been alluded to earlier on around the staff issues that may arise when we come to staff frontline testing, and I think that does have a cause for a note of caution that we just need to keep monitoring it and managing it, because it is likely to be something that we are going to need to be very careful with and very vigilant over. That would be my risk.
Thank you. Steve?
Yeah, Melanie, the only thing I would probably add is, obviously, as we tackle with COVID and winter pressures, there will be an impact on the delivery of the elective programme, and that might well have an impact on quality, particularly around long waiters.
Thank you. Joe, anything further from you?
No, I think I covered them in my updates. I share Steve's and Alice's concern, and we're robustly managing the elective programme, and we are adamant to keep those beds ring-fenced, because we're very much aware that people that have waited more than a year for their procedure are equally as in danger as people coming in as an emergency through the front door.
Yeah, absolutely. Thank you. Thank you. And clearly these are pointers that we will need to note in next month's board meeting with particular rigour. I just wonder, I know colleagues will have comments and questions, but Lois, maybe you could just lead us through what we need to do for the quality account. Then we'll have some questions and then we'll have a break.
Yes, I was going to give a lovely presentation about it, but Tim has completely stolen my thunder, and so I won't bore everybody with the detailed notes that I've made. The key themes have been continued into the coming year because they have been found to be giving us very helpful overarching framework into which to plug our various new improvement objectives under the holy trinity of quality of patient safety, patient experience and clinical effectiveness. The Trust met a significant number of the objectives it set itself last year and should be commended for that. And as Tim has said, has been commended by a number of our partner organisations. And we look forward to delivering under the identified metrics, which are in part 2 of the report, which indicate how we will monitor and measure whether or not we are delivering the improvements required. So I would ask, subject to the correction, which we have very helpfully had pointed out to us in the chat, many apologies for that mistake, we will get it corrected before it's published any further. I would ask the board to approve and adopt these quality accounts, which we will then submit to NHS Improvement.
Thank you. And I apologise, colleagues, for this being a bit of a mixture in quality of backwards and forwards, but I think it's important if we keep our minds focused. And I'll come back to the actual final approval, Lois, in a minute. Caroline, you have a question?
Yes, I mean, first, I think congratulations to the team. I think it's one of the, my time on the board, best presented quality documents that we have. So, well done for that. I think it shouldn't go unpassed to sort of recognise that compared to things that we have delivered in the past. So thank you very much for that. Two points. One around our first priority. The one thing we didn't do, the implementation of the electronic observation system, we say very little about why we didn't succeed against that objective, compared to saying an awful lot about our successes in some of the other domains. I can imagine why, and it was more a question about and what will happen to that one next year.
Thank you.
I'm quite happy to pick that one up if that's helpful. Sorry, I was trying to get off mute quickly. So I think you raise a good point, Caroline. It will be part of the wider digital programme. So we're looking for new platforms elsewhere, and what we didn't want to do was implement an electronic system for observations that then didn't align to whatever that wider system change was. So it's been put into the wider programme. It hasn't been lost.
Thank you. Darren? You're on mute.
Thank you. Alice has just said exactly what I say around the digital and e-observations, so nothing further to add.
Thank you. Thank you very much indeed. And therefore, I believe that subject to the slight adjustments, as you say, Lois, the board is prepared to approve and adopt and publish the quality accounts for last year. And thank you very much indeed, noting its real interest and significance to the work of the board and how that has improved over the years. So thank you. Thank you. Right, it is now 2:45. We are supposed to be somewhat further down the agenda than we are now, but would you, Phil, you've got a question?
Yeah, so just in relation to the quality accounts, there's a section for trust response to stakeholder statements.
Yeah,
so
that
needs to be completed, doesn't it? So particularly, I think, in relation to things like there's reference to more digestible format of the quality accounts.
Yes, absolutely. We will put that in. Thank you.
Thank you. Yeah, that's usually the case. They can't comment until they've seen it, so that always the comment comes after. Right, I think in that case, may I suggest we have literally a 5-minute break or so, so that we can continue with our focus on the important matters next of finance. So I think stay online, turn your microphones and videos off, and we will reassemble in 5 minutes. Thank you. And are we all back? I think so. Well done. What you do in your 5 minutes is your own business. However, welcome back. Hopefully somewhat refreshed. And Darren, because I know that there was no Finance and Investment Committee this month, although the cycles will, of course, fall into place shortly, I would be very grateful if you could present the financial aspect of the IPR. But Caroline, I think you have also scrutinised the IPR in any event for this month, so you would be able to add your assurance to what Darren is about to tell us, I think.
Yes, I'm ready to give some comment.
Thank you. Darren.
Thank you, Melanie. So just for ease of reference for those following the papers, it's page 296 of the whole pack, or page 50 of the IPR itself, towards the end of our whole pack. So finance headlines for me up to month 6, which is the end of September. I'll talk a bit about that, and I'll talk a little bit about the future from month 7 to month 12. So successes that we've had, but also risks going into the remainder of this financial year. I'd also like to have a brief moment to talk about the Investing for Our Future programme that I think the board and the public will find incredibly interesting as we move forward. So 3 kind of big topic areas just to take the board through now, Melanie, recognising that Caroline will come in and provide a level of assurance after I've finished. So month 6 position to start with, we've seen a break-even position as at the end of month 6, now in line with every NHS organisation, and crucially after receiving what's called top-up funding from the Department of Health and Treasury around our excess cost over income and our COVID costs. All organisations have been able to break even where they've had an excess of cost over income in direct response to the COVID pandemic under wave 1. So that's up until the end of month 6. That, really importantly for the board to note, has changed for month 7. So there is now not a retrospective claim methodology. It's now very much what I've referred to as a live budgetary situation from month 7 onwards. We have a fixed allocation that includes an estimate of our COVID costs and any top up of excess cost. But it is our budget now to manage rather than a retrospective claim process direct from Treasury. That presents a level of risk as we move forward, in that we have planned for a certain level of activity and a certain level of response to COVID pressures, to demand increases through winter, and a certain level of restoration and recovery activity as we agreed at board in September, if colleagues will remember. What we don't know, of course, is whether that level of activity will be at the level that we've planned for and we've assumed. So the risk, therefore, needs to be kept as very much a live process. And what Caroline and I have talked about and agreed is that a monthly forecast for across each of our divisions and corporate areas will be presented to the Finance and Investment Committee on a monthly basis, and then a report will come back through Caroline as chair onward to board. So we'll keep that very much live and ongoing. The enhanced financial controls that we have within the organisation should enable early sight and early warning of any of that potential variance in response to that risk and demand change. The next point really is a bit more depth. We've talked today already about the level of staffing that we have in some of our areas and the coverage that we have with agency and locum staff. As our COVID costs potentially increase in response to that demand, that's certainly a level of risk that we need to be aware of as we move forward from months 7 to 12 in that live budgetary performance. The longer term plans, of course, is as we add more recurrent costs to our cost base without the commensurate income being available from our commissioners and from the wider STP system, that could lead to a further imbalance between our income and cost, and that push us further away from longer term financial sustainability. So what we've agreed is a very early analysis of that recurrent and non-recurrent components to our cost base, and that will be presented back through and a live document talked through within and agreed through the Finance and Investment Committee as we move forward over the next months in preparation for our financial plan from the 1st of April next year. So we've definitely got some risks as we move forward from months 7 to 12 and longer term too. We've got a number of mitigating actions in place, and we've got a controls mechanism to ensure that regular information is provided to parts of the organisation at a budgetary level through divisional performance review meetings and the Finance and Infrastructure Committee as we move forward. I think critically some key achievements in this period. All our revenue, COVID revenue cost-based claims have been reimbursed. We've agreed the month 7 to 12 plan, and that's been signed off by the board and has been accepted by the STP, the ICS, and the regional office teams. We've got enhanced financial controls in place, and they're being regularly monitored by the Financial Recovery Board, the Finance and Infrastructure Committee, and progress reports being reported back through the Audit Committee that Phil chairs. We've managed to secure some additional funding, actually, really excitingly, from a digital perspective, working with mainland partners, that's Portsmouth and Southampton. We've managed to secure some additional funding, both capital and revenue, for digital outpatient work, which is a fantastic achievement of the teams. We've regularly now disseminating any of the financial board recovery messages throughout the organisation, which is really important. It's not just a small group of people at the top of the organisation that are managing this financial recovery. It's all of our staff, and really important for everybody to know how and what they can contribute to that. And as I think Nikki said earlier on, we've managed to secure some funding for the Isle of Wight and the Portsmouth partnership, acute partnership, around the funding for the programme team. A couple of really important things around cash and our payment policy for our local businesses and suppliers. Because of the change in financial regime for months 1 to 6, the cash situation within the NHS is very different at the moment, and the advance of cash to enable businesses and suppliers and staff to be regularly paid has been a massive, really massive positive for the island community, but for the NHS and the suppliers at large. Pleased to be able to say that for September we're in excess of 96% of all of our suppliers paid within our payment terms, which is a fantastic improvement. and that compares with a year-to-date position of 92.1% against a target of 95. Clearly, at the start of the year, that financial regime and the cash was taking some time to work through. Our capital plan is progressing at pace. We have 5 different perspectives or themes within that, really, and that what I call a business as usual capital. We ask, well, risk going forward is that the COVID capital costs that we've incurred are not fully reimbursed from a National Treasury perspective. We're not unique in that all organisations are going through that reimbursement process, despite us adhering completely to the rules that were in place at the time. Last point from me, really, Melanie, before I finish, is the investing in our future our programme, which is in simple monetary terms, the £48 million investment that we bid for and were successful in granting as a funding source for our delivery of our trust strategy, progressing really well across our domains for each of those. That isn't just digital, it isn't just estate, it relates to our community investment programme as well, and our hubs in our wider community. So that's progressing really well. We've got a programme board in place now, and all system stakeholders, including NHSEI and other mainland stakeholders, are part of that. And that is a subcommittee of our finance and infrastructure, and regular reports are provided to that committee. Pause there, Caroline. Pause there, Melanie. Apologies. Pause there and invite any comments and questions.
Well, no, I would certainly invite Caroline, perhaps, please, to add anything to Darren's report.
Yes, thank you. So as we're aware, we haven't had a finance and infrastructure meeting this month, but we will do so going forward to align with board meetings. But I have had a one-to-one with Darren, and we have looked at the reporting together. So if you remember, we have submitted our revised financial forecast for the end of the year. So at that point in time, at the end of month 6, we had a fair amount of scrutiny as to those numbers, and I'm assured that no further significant financial risks have occurred since that point in time. We've looked briefly, not in this reporting, but at month 7, and Darren has assured me that we are more or less on track for month 7. So that looks as if, you know, that further sort of increases one's assurance. There's one financial risk that Darren hasn't brought to our attention, but is in the report. You should be aware that we haven't yet recovered the, whilst we've recovered our reimbursement claims for revenue from the NHS, we haven't yet recovered the capital claims. So that is outstanding. It's about 800k according to my notes. So that is a risk that is sort of sitting in the system. Also, I think Darren leads me to be relatively assured that, you know, this is not going to be a problem ahead, but there is certainly a delay in this one. We've looked at the reporting as well, and I think there are some sort of whilst I think we've made a lot of progress in terms of sort of the reports that highlight the risk and the mitigating actions to those, and the divisional reporting as well. So thank you everybody for that. I have suggested some improvements which we'll discuss at FNIC as well about, as Darren says, the look forward, the perhaps less concentration on in-month comment and more concentration on where we're going forward. And we've also looked at the capacity reports, which again, thank you very much for that, both Julie and Darren, to sort of try and get to the bottom of sort of the difference between people and the cost of people. And we've also discussed some improvements there to give us a bit more clarity in this IPR if other board members found it challenging. We're going to take that away and work on that. So the reporting is still a bit of a work in progress, but certainly some positive move forward there.
Thank you very much, Caroline, and I am reassured that no further risks have been identified to the stated position at the end of last month. That is really helpful. Any comments from colleagues? We note the need to, we're part of the same boat in recovering COVID-related capital claims across the system. So I think that's not specific to the Isle of Wight, but worth bearing in mind. Yeah. Thank you. Darren, I think you have done such a good job that there are no questions.
Thank you, Melanie.
Well, thank you and Caroline for that assurance. I think that's really helpful. Not that we wouldn't have had questions if we hadn't had the assurance provided by such outstanding papers. So thank you very much. Anne, very important people and organisation committee.
Okay, thank you, Melanie. What I will do is, obviously there are a couple of items here where, sorry, I think this door.
It would happen. Yeah.
It always happens just at the wrong time.
Indeed.
I think there are a couple of items that came up, obviously, in the People and OD Committee, which you're going to be separately reported on. The Freedom to Speak Up Guardian and also the Guardian for Safe Working for Junior Doctors, and I'll leave them to make their reports separately. So if I can just take you through. They've gone. It's okay. If I can just take you through the other items, okay, and which I'm sure you'll have all read the report, and just pick up on perhaps a few of the points, because obviously the first thing that we looked at in the committee was the integrated finance and workforce performance report. And just to say, actually, that the committee really welcomed again the oh, okay. I see Lisa and Raj are not attending. My apologies. I will say something about it then. I've just been informed about that. But just to say that the committee did welcome the new format report, which included the sort of alignment of financial matters with workforce matters, particularly around capacity and pay, and that was welcomed. So thank you very much for everyone for doing that. Now, obviously, in the report, perhaps the key areas to make the board aware of are some of the issues around particularly recruitment. I mean, recruitment obviously remains an area of risk for the trust. I mean, there are some good news in the sense that there is the collaboration with Yeovil, which will help bring in overseas nursing cohorts. There has been a successful recruitment of international nurses, and there is another drive going on there. But of course, we now are in wave 2, and there are constraints, obviously, that are being placed on getting international nurses into this country at the moment. So there is some risks around those particular areas. And there are also risks around medical appointments, which are well documented, and obviously we'll come back to in the medical director's report, notwithstanding the fact there is progress being made in some joint appointments, but there are also certain specialty areas which we know are very difficult to recruit to. So I think there are those particular risks, and they remain of concern to the committee. Although staff sickness is within the sort of realms of what wouldn't be overall is fine, I think there were concerns raised about staff sickness, obviously, particularly in the light of what's happened through COVID and the ongoing pressures they're going to mount up again, especially in some of the acute and other clinical areas. So I think just the board should be aware that concerns were expressed around that. The committee was, I think, encouraged by engagement, staff engagement, which seems to be improving, and just so that the board is aware, one of the things that have come out of the discussion was the fact that we were going to start doing a gap analysis around some of the results on the staff survey, and particularly to try to focus that around issues about the sort of key family and friends tests and things like that, so we could really understand how we could improve what we do in this particular area. So that's something which we'll come back to later, and we hope will help give us more information and see what we can do to make things better in that area. In relation to health and well-being, all the initiatives were well reported on at the last board meeting, but one of the things that came out of the discussion was that we are going to, next month, I get a mental health practitioner to come in and talk to us in particular about well-being in staff, so that we get a much better understanding of what's happening in that particular area. So, I mean, those I think probably are the key things that came out of our discussion. Going forward, I think the committee did welcome the new form of report, and I think one of the things that we'd quite like to see going forward is perhaps get a better sense of perhaps timelines and trends, so that we could just see about the sustainability of the changes that we're beginning to see happen across this particular area in relation to our performance. So, I mean, obviously reasonable assurance essentially, particularly around the development of initiatives in this particular area, and that we're getting better information now to base that assurance on for the committee. We were intending originally to do a deep dive into staff exit interviews. Now, obviously, this was something that was slightly put on hold when the committee was suspended. And so we brought it back to the committee. And so what we only had this time was an interim report. And of course, it was based very much on a very, very small sample. So I think going forward, I think what we're concerned with was that we'll try and focus on very particular groups and see if there are hot spots around, which we may need to look at, so that we can understand what any learning that arises out of these sort of staff exit interviews, to ensure that the trust can improve its processes. I think one thing that came out of this is that instead of just talking about exit interviews, perhaps what we should be doing in order to show that we are implementing effectively a retention strategy is not so much exit interviews, but what we might call stay interviews, because what we want to do, okay, is stop people from leaving. And anticipating that we should be able to do things to contemplate that. So I think that was, again, reasonable assurance around that. The business case in relation to the e-job planning software, which is being funded by NHSC and NHSI, the committee obviously supported the option 3 that was being proposed in that business case, and which we'll now move on to finance and infrastructure. To consider their recommendations to the board following on that. The medical director's report, and I don't know whether Steve will want to comment on this, but we were really pleased to see the progress that had been made in relation to the GMC visit and also the health education visit. And we noted that there had been significant progress which had been made in preparation for the visit, and there was a considerable hope that enhanced monitoring could be removed. And it was good to know that any outstanding concerns, for example, around IT, were being picked up inside the medical directorate. Likewise, good progress being made on the implementation of the new national appraisal process, which was very encouraging. And the other thing that we looked at in the relation to the medical director's report was obviously the annual organisational report for revalidation. With that being presented to the committee, it was confirmed that it has been undertaken. It was ready to be submitted for sign-off by Maggie ahead of submission to the AMC, but there were 1 or 2 points of clarification and amendments which we wanted to happen before that went forward. So I don't know if Lois will be able to confirm that, or Steve, that those minor clarifications have been done, and we would recommend its sign off then. The other thing was medical recruitment. Again, we received a good progress report, which included updates on some of the joint positions, for example, advancement of plans for stroke, which was encouraging. But there were still some concerns, obviously, around this area, particularly in relation to the problem with recruiting junior doctors. And obviously there were certain specialities which remain very difficult to recruit. So there is ongoing fragility in that area. I don't know, Steve, whether you wanted to comment on that.
Yeah, I mean, I think in relation to the headlines that you drew out of the medical director's report, I think first of all, I would like to report to the board that it was a very positive report from the HEE GMC visit. They had noted significant improvements around educational opportunities, educational supervision. They'd noticed an improvement in the culture of the organisation, and they were starting to hear from trainees that they would actually start to recommend this organisation as somewhere to come to train and possibly work at the end of their careers, which I think is a huge step forward to where we were a couple of years ago. Yes, there were always going to be a couple of issues that we needed to address, particularly around relationships and referrals from the emergency department to specialties, particularly out of hours and at weekends. But overall, I think everybody heard the hot feedback, and we've not received the report yet, but the hot feedback certainly was very positive. And as Anne said, we hope to be able to come out of enhanced monitoring. In relation to the appraisals, the process has changed for this year, and it very much is a very rapid health and well-being check-in with your appraiser, and we have a robust process in place to deliver it. The issue that I think pervades many of the areas that we've discussed this afternoon, particularly around the partnership working, is around recruitment to our difficult to fill specialties. The specialties that we struggle to fill are exactly the same as that there are national vacancies, and therefore what can we do as an organisation or as a partnership to make us more attractive to potential candidates. So I think we have a short-term problem that we need to address within the organisation using a locum workforce, but we continue to progress our plans through the partnership to reduce the fragility of some of our services.
Thank you.
Thank you. And I think I'd just like to say, actually, I think it's very nice for the committee to feel that this time we feel we can give reasonable assurance around this area, which is an area which has been of much more limited assurance in the past. So I think a congratulations to all the team, really, in relation to the successes that they've managed to achieve in that particular area, really.
Absolutely, yeah.
So if I just turn then to Raj's report, the Junior Doctor's Guardian of Safe Working report, as he's not here. And we obviously received an update for him for both the period April 2020 through to September. So that's both Q1 and Q2. Actually, there were no reports, I think, exceptional reports in Q1 and some exceptional reports in Q2, but that was a huge improvement from where we have been in the past, which I think is worth noting. I think overall, the feedback from the junior doctors was much more positive than we've had in the past, but it was still noted that there were challenges being faced by staff during this period and obviously during the COVID period. One of the things I think I would just like to flag up for the board is that Alistair, the medical director at the time, did congratulate the juniors, and I think this was very much welcomed by the Guardian, on helping on covering during COVID, and because they had sort of really stepped up to the plate. I think the good thing that came out of this report in particular was that it was very encouraging to see the juniors actually, for the first time in a report we've had for a long time, felt they had been supported, well supported by both seniors and management inside the trust, which I think is a major improvement going forward. And again, everyone should be congratulated on that. And just one other thing I'd just like to add, actually, which the board I think would be good to make aware of, is that we had a very nice thank you from the Guardian himself addressed to the committee, because I think the Guardian themselves felt that the committee was giving a level of support to what was happening in relation to issues around safety and concerns that had been raised by juniors, and felt extremely well supported by what the work of the committee too. So I think it'd be nice just to flag that up. The Director of Nursing report was also given, and we received an overview of all the activities across the different areas. I think in terms of there were some concerns raised about sickness in relation to on maternity, and although there were a rise in number and term admissions on the special care baby unit, it was felt that they were appropriate, and so I don't think there were any particular concerns in that area. It was good to see that they, obviously I've already mentioned about the changes that have been happening in relation to overseas recruitment and the collaboration with Yeovil. It was a good update in relation to dementia and on the Medi audits. And one thing that came out of the committee was that it was mentioned that it might be very useful to share some of the information that came out of the Medi audits with the digital committee itself. So I think hopefully that's something that they will take forward. Conversations on the frailty pathways had started, which was very encouraging, and also all the pastoral support was already being put in place, and that was beginning to go at a pace. So I think there was quite a lot of good news in that area, and progress being made on the apprenticeships. And so I think overall, I think there was substantial assurance around what was happening, but still aware that we remain at risk in relation to certain nursing recruitment at this moment in time. The Freedom to Speak Up Guardian report, we had a report from Lisa to cover again, 2 quarters, April 2020 and to September 2020. The report was in a slightly different format from what we'd had before, and noted, and there were obviously a number of things that were brought out which were designed to help implement and support staff during the COVID period. I think the key thing to note that came out of the report was that there had been a decline in cases of bullying and harassment reported. But having said that, where there was an increase was what were in other areas. And the other areas, of course, included other forms of behaviours, but these were not registered as bullying and harassment, and there had been an increase in these areas. What we don't know, because the information isn't quite broken down yet, is the nature of those behaviours, okay, which are still raising some concerns. And so hopefully going forward, we will get more information around those kind of alternative behaviours which are not bullying harassment, but other ones which are perhaps not quite appropriate, that we need to understand more so that we can actually act on it and make real improvements in terms of what we deliver in this particular area. So, I mean, the information we felt was very helpful, but we just needed to perhaps drill down a little bit more into understanding some of those particular behaviours so that we could actually put things in place to change what was happening inside the trust. But overall, I think it was very encouraging that we'd had a drop in bullying and harassment. I think the only other thing probably that I just need to mention is we didn't actually manage to go through the board assurance framework because at this particular meeting we actually just didn't have someone who neither Lois or Sarah were available to perhaps take us through some of that in detail. So we are going to have a more detailed discussion on that at the next meeting. And apart from that, I think the committee felt that overall there was reasonable assurance across most of the areas which we're concerned with. Recruitment remains probably the key risk in this particular area, and also I think we are very aware that perhaps we need to look at what's going to happen in wave 2 around staffing issues, whether it's capacity or sickness, well-being and things like that, that we may need to address going forward as potential risks that could increase as we enter into the winter phase with this second wave.
Thank you very, very much indeed. What it strikes me in particular, colleagues, is how important it is to have this committee functioning to give board the assurance at this level. And the amount of work that you have already got through, Anne, is really appreciated. Just checking the notes, if I may. I think both the Freedom to Speak Up report and the junior doctors' working hours are just for noting because they're not the annual reports. Right, so we don't need to make any formal resolution, just to note.
Committee wanted to commend to the board.
Yeah, thank you very much. Now, again, we do have some comments from colleagues, and if I can ask colleagues to put their points, and then we'll come back maybe to Julia, because Julia, I know that you would like to talk about the 3 risks going forward, maybe this month following Anne's report on the committee. But if we have the questions, and then maybe you'll be able to round them up together with Anne. So, Caroline?
Yes, it was a question on the junior doctors. Like others, I was pleased to see, the progress there, but just slightly puzzled by the imbalance between the overall conclusion that said they felt well supported in this period and the extreme frustration, I think, with the issues on medicine rotas. I don't know if Steve had some input he could give me here.
Thank you. Yeah. We'll come back to that at the end, maybe, if we just see the areas. Julia, I know you've had your hand up a long time. I apologise. Julia?
It's okay. I'll be very brief. As a member of the People Committee, we were absolutely delighted to see the Integrated Finance and Workforce Performance Report. It's still work in progress, of course, but it's so important that we can look at those 2 areas together. And secondly, I don't think you mentioned it, Anne, but of great importance too is the Black and Ethnic Minority COVID assessments, which we were reassured is being carried out very proactively. So just those 2 points. Thank you.
Thank you so much. And Kemi?
Hi. I think mine's a question to Julie about the Freedom to Speak Up report. I'm not really clear how it directs change and the extent to which it's used to identify any systemic issues that need to be addressed. And I was hoping you could give us some feedback on how it's used.
Thank you, Kemi. I mean, this is an area of development with our Guardian. I think we've been lacking in being able to demonstrate the so what of the issues that are raised, and equally whether or not all of the issues that find their way filtered through the Freedom to Speak Up route is the most appropriate route for them. So we're doing some work with the Guardian to ensure that we've got an overarching framework that is making it easy for our people to raise concerns, and then ensuring that we close the loop on the impact of having raised it, the so what. And I think it is a gap for us that we're working through. There's been an engagement week at the end of October that the Guardian led with staff, and there's some key recommendations that come out of that. But it's a key point that you raise, Kemi, and one that we need to carry forward.
Okay, thank you.
Thank you. Steve, do you want to cover the point about junior doctors?
Yes, in response to Caroline's question, I mean, the absolute number of exception reports reported or submitted is actually relatively low. Organisations of this size sometimes have significantly more. And if you think this is over a 6-month period, you're looking at 1 to 2 reports per week, which could be a doctor reporting that his shift overran or her shift overran by 1 or 2 hours. Yeah, the challenges have been in medicine, and it really does come back to the theme that came out of the discussion at the committee around recruitment, because not only do we struggle to recruit at consultant level, we struggle to recruit or be allocated trainees at middle grade level. So sometimes the juniors do feel unsupported for periods of time, but the absolute number of reports and the content of the reports are such that I don't think they present a significant patient safety risk on a day-by-day basis. Yeah.
Thank you.
Thank you. And Julia, is there any other point you wish to come back on?
I think
the risks going forward.
I think it's been raised really. Recruitment is the hot one. The sickness absence and really the health and well-being of our staff responding through the pressures that they're dealing with. But the last part that we haven't talked about is the EU exit. Recognising that we've over 130 EU nationals working within the Trust. We're reaching out to them to understand how we can do more to support and encourage applications to the settlement scheme. Earlier in the year, we held some communication events and we held a legal briefing. So it's really considering whether or not there's more, because I'm sure there is, that we can do that will support that important part of our workforce.
Thank you. And I think the whole board would support you in that. Absolutely. And also, I'm sure the whole board would like to join with me in confirming that the health and well-being of our staff through the next few weeks is absolutely paramount. So thank you very much indeed. Colleagues, I think thank you, Anne, very much indeed for that work. I think we now move on to Kemi, the Digital Transformation Committee, please.
Hello. Yes, I will assume the report has been read and I will just go for some highlight points, both as a report from the last meeting and to give you a forward look about what we're planning to do in the next month. So starting with the strategic area of work, we were really keen to start to understand the status of existing projects and the extent to which they're aligned with the Trust's objectives. So the Trust did a significant amount of work between the last two meetings of our group to start to assess the status of projects. And we were encouraged, the committee was encouraged by the work that was undertaken, but we could only give limited assurance about the alignment between the governance of projects and their alignment with the Trust objectives. I'm sorry, I don't have a dog, but I have a cat that's trying to join the proceedings. So, sorry, I should now focus. She's gone away. Apologies. Yes, so essentially we give you limited assurance around that, but we're very pleased that the team are now getting to grips with whether the projects are actually ones that we should be pursuing, or whether some of the projects should actually be put on hold if we can't assign a senior responsible officer. I would like to report about the really positive impact of having established this committee, because the executive team were approached by the regulator to provide a Trust digital strategy as part of the evidence to support the £48 million SOC. The feedback that Darren and the team were able to give us was that the regulator was very reassured by the fact that we had plans in place and we had a proper stakeholder engagement process in place for developing the strategy, to the extent that they moved away from a position where they urgently wanted to see a strategy and instead moved to actually wanting to engage with us and work with us in the development of our strategy. So I think that the fact that we're able to give the regulator confidence because the committee exists and we have a plan of work in place was really helpful to us as a Trust and build confidence with the regulator. So I thought I ought to report that to you. Finally, I want to go, in terms of the work that we discussed at the last meeting, the key point is that we now have a clear plan for developing a digital transformation strategy, and it's due to be presented to the board in February. Now, this is a point where I would like to announce the happy news that we now have a CIO appointed across. I believe it's. Am I allowed to report that formally? Yes, good. I'm just looking over. So photos are over there, words are over here. So yes, we formally appointed a CIO, a joint CIO across Portsmouth and Isle of Wight, and we're really looking forward to him joining us and being part of this process of developing the strategy and taking ownership of it going forward. So as I said, I'd like to focus on what we're going to be doing over the next month. The first is that the teams are working on developing the draft digital transformation strategy, and we'll bring it to the committee to review at our meeting later this month. I'm looking and hoping for a level of ambition in that strategy, but also clarity that there is ownership of the elements that we're putting forward for development by both staff within our organization and partners who are being consulted about how our delivery will affect theirs in this space. Really importantly, as we develop the strategy, we understand and recognize that there are current issues with clinical systems and the need to renew or to actually completely replace existing clinical systems. So we're trying to do the very careful balancing act between developing a long-term strategy and making sure that we don't actually spend ages on strategy and don't actually deliver. So next month, one of the things that's going to be brought, later this month, one of the items that's going to be brought to the committee is an update on the clinical system strategy and the opportunities for delivering some of the services earlier and meeting the needs of clinicians and the public sooner rather than later. So we look forward to that report, and we hope to be able to tell you next month something about what we might be able to do in advance of the ratification of the long-term strategy. And finally, probably one of the main reasons for establishing this group was the concerns raised at board about the cybersecurity. And I'm happy to report that we have had reassuring reports from the executive team. But what we're now waiting for is the update from the security audit on the latest feedback from the exec team. We don't have that yet, but we're hoping to take that later this month, and it will ultimately be reported back to board as to the level of assurance that we now have in this area. And that's it from me. Thank you.
Many thanks indeed, Kemi. Really grateful. Darren, I don't think you would have anything to add to that, bearing in mind that this committee is new and clearly does need to provide itself with a work plan. So I'm not sure that it's right necessarily to ask you if you can foresee any 3 particular risks this month, apart from cybersecurity, data information, and the ongoing issues which has always existed for the digital agenda.
I think that's right, Chair. Just very briefly, and I know I'm really conscious of time, we're working really well with Portsmouth colleagues under the acute partnership to look at commonality of improvement. So, for instance, an infrastructure development programme as far as we can, or a clinical system, and Kevin's touched on that, so I won't dwell on that. The one risk I would just flag, of course, is moving at pace with a small team across 4 services and a number of partners presents some operational prioritisation challenges in terms of risk for staff and responses. But that's not a new or a unique situation to IM&T and digital. It's pretty common across a range of our staff groups.
That's a point well made. Colleagues, I think there are 2 hands up, but they may be old hands. If that's the case, and again conscious of time, Lois, I'm going to hand over to you to do the next 3 items straight off, please.
Absolutely, Chairman. These are matters of procedural propriety that are just on the board, so that we have the minuted confirmation that they've been through our proceedings. The fit and proper person test just describes in quite a lot of detail, so thank you, Sarah, that the process that has been undertaken, which I hope provides you with assurance that we are all appropriate people to be around this virtual table. And the declaration of interest is just the confirmation that our annual update has been undertaken, and the register of interest will be made available in its corrected form, and thank you, to the public as it always is.
Thank you. And the last item, questions from the public. I don't think we've had notice of any that need addressing at this board, is that right?
I think Lynn put the only item on your annotated agenda.
Yes, but that's going to be a freedom of information request?
Absolutely.
Yep. Thank you. Right, colleagues, in particular, and observers, I would, if you've got 2 minutes that you can bear with us, just any other business before we finish, and then I'll ask colleagues if there are any other questions. No. Right. Thank you. Thank you very much to members of the public who have attended. We're really grateful to you, particularly as we have slightly run over time. But I think, and I hope you'll agree, that the agenda has been of particular significance as we are going into this winter ahead. So all thoughts, all support and all encouragement to our staff for their continued delivery throughout this next period. And indeed the support of partners and attendees and those who have attended this public board meeting would be gratefully appreciated. I have absolutely no doubt by everybody involved in the delivery of this service. So thank you to all of you. Really grateful. I think I have no other matters to mention except the date of the next board meeting is the 10th of December, which isn't very far away. And also just to colleagues on the board, we will resume in at 3:45, please, for the private board. Thank you all very much.
Thank you. Thank you.